So this is sort of a redo from the February 2nd attempt when we got Zoom bombed with the presentation. I'm not sure how many folks tuning in have seen the last presentation or how many are new. So we'll try and do some review of what we talked about, or a lot of review of what we talked about before, and a few new questions that were sent in by listeners or folks tuning in. But the main goal of this is to make it interactive. And so as you think of questions or have comments, please chime in through the chat box, and let's make it interactive so that it can be a little bit more of a two-way discussion here. So a lot of the talk is going to focus on pediatric headache, primary pediatric headaches, particularly migraine, and outpatient management. So I have nothing to disclose. That I might mention a few brand names and non-FDA approved treatments, but for the most part, this will just be a review of migraine management. Again, I'm going to go a little bit more briskly through our situation with our workforce here, and then trying to focus on optimizing headache management in the outpatient setting, and kind of provide some guideline on when to send for referrals, and to help our referral efficiency to help us help your patients. Because in the big picture, we want the right patients seen at the right time. And right now, we just celebrated dropping our wait list from 396 to below 300 patients. So on one hand, it's going in the right direction. On the other hand, 30% of our referrals are due to headache. And so if there's any way to trim those down, and that doesn't even include those that we try to send back now. So now I'm trying to send more back if I feel like they can be, managed a little more outpatient. So by sending the right folks at the right time, it helps us to help the right patients at the right time too. And so again, when sending a referral, it's helpful to have notes documenting the condition and how it's been evaluated outpatient. And then if someone feels it's urgent, which often gets stamped at the top, it's helpful to know why it's felt to be urgent or not. And we'll go through more about red and yellow flags that might raise things on the priority list. So also out there's a headache guideline that we put together for HHP. This is the link, but if you search like HHP guidelines, this is kind of a flow chart. It looks a little complicated, but we'll try and go through it and break it down throughout this presentation. But it's just to try and help with the process of kind of approaching the patient with headache and then having them seen at the right place by the right person. This next slide is just a note to myself about questions that you folks have sent in that I'll address throughout the presentation. So this is a different real life vignette that came in after the last talk. And, just kind of an example of what gets sent to us. So patients having a second migraine, went to school, didn't make it through the whole day, gave them some over-the-counter medicines with caffeine in it, trying to cut back on screen time. How long does it last? How do we speed up our recovery? The other days, so he's out other days of the week, in fact, the whole week for other issues. Mom's frustrated. Should I be worried? He's always dizzy. And so the response to the patient message is maybe send him to neurologist, no follow-up. And so this is just a kind of a real-time, real-life example of is that the right next step? I think that it would be good to follow up. He has other history. Does he have obstructive sleep apnea with history of obesity? He already has a diagnosis of irritable bowel syndrome. After this, referral, I went back to the chart, and he's been seen by a counselor and has adjustment disorder and anxiety. And so mom's worried, but the next best help probably is not going to be sent to neurology, but really got to meet with them and kind of fish out what's going on and what they're worried about, and address the different factors that might be contributing to the missed school. And this one I went over before. We got an urgent referral for headaches for 2 years. And to me, one red flag is if I get a referral that's based on a well child visit, I have to wonder, really, did they happen to show up just having to need a referral, or is that a way to uh, to have them kind of shunted to get taken care of? Because after this well child visit, then they said follow up in a year. And so again, help us to help your patients by following them, kind of working with their headaches until they get to a point where you really feel like neurology consultation is needed. And so again, although Epic patient messages are very convenient, we really ask that patients be actually seen for their headaches. The exam and history are super important, both for us and even for the temporal course of managing the headache, because we do want to rule out red flags that might warrant a more urgent evaluation, and at least think about yellow flags that might still warrant something more expedited. And then if we've ruled those out, then what can we teach the family about headaches, how to optimize the lifestyle habits to minimize headaches, and how to help them. And this is before any referral takes place. So these are important steps that we want to address and not make the first step to be referral. And then the important thing also is follow up and repeat. So a first time headache visit, most times, unless there's red and yellow flags, should not lead to a referral. Often it takes, just like in getting us to change a habit, even though we tell folks drink more fluid, sleep more, often it's not an instantaneous lifestyle change. And so we just want to verify, is it actually happening? And so if we've optimized the lifestyle habits on a consistent basis and they're still chronically bothersome, then I think that might at least make it more reasonable to refer to neurology, but we'll talk more about other steps. But at least we hope that the lifestyle habits are consistently optimized. Often we worry about, is there something serious going on? But headaches are quite common in pediatric patients, and often they can be recurrent. But often the most bothersome headaches that come to attention are due to migraine, which is a primary headache problem. And serious pathology is actually rarely a cause. And often there are other things on the history and exam that we can do to exclude that as a possibility. So we can focus on managing their primary headache problem, which it often is most of the time. And so along that note, there was a study done a while ago in 800 children who were referred to a headache clinic. And in their evaluation, who were referred to a headache clinic and had brain imaging, less than 1% had pathology, serious brain pathology that needed to be addressed. And 2 of them were predictable based on their clinical findings before the imaging. 1 was unexpected, but manifested at a later stage. So just some reassurance that headaches are pretty common, but serious pathology is not. And so again, one of the first things we want to separate for headaches is it a primary headache problem or secondary to something else causing the headaches, which can be a long list. Most commonly of all of these, probably we're seeing headaches related to infection, and often those are pretty straightforward and folks can identify that and may not even think about any concern for referral. But probably next up are primary headache syndromes that are bothersome, and of these, migraines are the most common. Tension types tend not to drive kids to go to see a doctor, but migraines are pretty bothersome. Patients are pretty sick with them, and they can be pretty worrisome for families. Concussions or other headaches secondary to other processes are also fairly common and should be sorted out from the history. And again, rare serious pathology is not common, and we'll talk more about trying to sort that out. Again, please chime in with questions or concerns anywhere along the way. And so first step, as we're trained, history and physical, and the the history, which again, I can send our headache intake form that we usually use, has a lot of headache-oriented questions toward it. It's helpful if the family brings in a diary if it's a recurrent episode, because recall is often biased toward the most serious episode or the most recent, and really want to kind of have a broad overview objectively of what's been going on. All the things that we use to characterize the headaches, excuse me, and looking for other things like triggers, other secondary cause of headaches. Do they have concurrent medical problems which might put them into a higher risk category? And then the social history, super important. Often we say, lives with mom and dad or et cetera, but such a big part of exacerbating headaches. So we do want to kind of delve into it. A lot of times I'll ask kids what they do for fun. And some of it's just starting, to get them talking, but, and also a big reason why I'd say in-person visits are so important in this realm of epic chat and telephone calls, because when you ask someone what they do for fun, there's a big difference between, or I don't do anything for fun, or like, oh, I like baseball, I like reading, I like, so all of those kind of start you wondering about other things going on in the person's life. And sometimes we have to kind of, as you know, peel things back for our teenage patients and really get to the bottom of what's going on. So although I often use the what do you do for fun as a springboard for the next time I see the patient to talk about something that they're comfortable with, it's often quite revealing too about their psychosocial situation. And then bothersome headaches. So there's the rating of headaches. Often we use kind of the faces for the younger patients, 0 to 10, for older folks. But the effect on daily activity to me is the most helpful objective part of how seriously bothersome the headache is. Because I'll have the patients like, 1 to 10, 10 being the most excruciating, unbearable possible pain you could have, and 0 being nothing. What number is it? They're like, oh, it's a 12. It's like, okay. And they're sitting in front of you, kind of conversing with you. And then I have, the patients we've hospitalized with migraine who are lying in the dark with their eyes closed, sweating, not wanting to move. They'll tell me it's at least an 8 or 9 out of 10. So numbers are one thing, and then seeing how it affects the patient, really to me is almost more telling sometimes. And also, why do patients say 12? Why are they saying 11? What's the reason for them even saying more than you could possibly imagine? And so, and so a lot of objectifying how it bothers them, and we'll go more in about getting history about what kind of treatments they've used, and about the exam. So one thing that often gets left off of the exams is a fundoscopic exam, and so helpful because that finding will definitely change the direction of the evaluation and treatment. Not something that patients will tell you about, but radically changes the management. And so as best you can, just getting a look at the optic disc, just looking at the borders, can be very helpful. Does that mean everyone with headaches should be referred to ophthalmologists? Not necessarily. But I think if we're worried about the headache and we're wondering how urgently this patient should be seen, that's a huge decision point on the evaluation kind of algorithm. And often what they use to help with the headaches. So sleep, we'll talk more about migraines, but sleep is kind of like magic. I mean, it's almost like nothing works sometimes for migraine until patients take a 1 or 2 hour nap, and then they're good. They're super uncomfortable, and then they're good. So just knowing that, like, okay, they slept and they got better, that really helps sort out a lot of things which should not get better just by a nap, whereas migraines are extra sensitive, extra responsive to sleep. And so again, stepping back, when we talk to patients, we want to look at their headache course over time. And so sometimes they may only they may only, oh, I realize my cursor is on the wrong screen, so you haven't seen my cursor. So they may only tell us about the most recent history of headache activity. Can you see my cursor now? Okay. They may only tell us about the last day or week of headache history, but we want to know their history over time because they may have very bad exacerbations, but very normal periods in between. On the other hand, they may have a gradual progressive increase in headache activity, which is actually to me more concerning than someone who had high peaks, but periods of normalcy in between, if that makes sense. And so, so you want to kind of try to get them to step back and paint this picture. Sometimes it's hard for them to paint the picture without keeping a log. And so again, looking at triggers, often they may not realize it until they start keeping a log and then look retrospectively at each headache. But as we know, things like stress, sleep changes, sleep deprivation, poor quality sleep, dehydration, skipping meals, etc., can be triggers for migraine, especially sensitive to bright lights, menstrual cycles, certain smells, etc., and even mild head trauma for migraine patients. So we know that patients with concussion who have migraine or family history of migraine, they have much worse headaches and a much longer recovery from concussion. And so all of these things kind of point toward the extra sensitivity of patients with migraine to stimuli that may not be as bothersome to the general population. One thing about the triggers, though, is sometimes it depends on how we ask the question. So, I'll see notes come from offices where, patient, patients sleeping enough and drinking lots of fluids, which to some patients might mean I have a drink of water with every meal, or I sleep at least 6 hours a day. Because I've had some patients tell me like, oh, yeah, no, I get plenty of sleep. I go to sleep at midnight and I wake up at 6. For a intermediate school patient, that's really not enough, but that's maybe their norm because of their study habits or because of their other extracurricular activities. But so we, instead of saying like gets lots of sleep, drinks lots of fluid, I would try and get something objective from them each time, so that later on when there's an exacerbation and we say, and they tell us, oh, they, their sleep or their hydration in the day or two before, we can contrast it to, remember when you were doing well and you had this much, and now look, see this time, and they can kind of start putting the cause and effect together. And so that really helps them get some control about motivation about lifestyle habits, as well as some inkling of control in how to help their headaches. And so this is one question. So in this talk, for those of you who are hearing it all again, at least there are a few questions from the audience that came in. And so these are new. So one question that came in after the last talk is there a classical type of headache for patients with high or low blood sugars? And overall, I'd say no. Some references talk about temporal pounding headaches, but I would say in general, you can't say, oh, that's a hypoglycemia type of headache. But in general, I think a lot of times folks are trying to look for causes. And we talked before about how patients with migraine are more sensitive to fluctuations in different things, whether it's smell or diet or hydration, et cetera. But in general, I'd say it's non-specific, and just try and get to the point of where there's certain foods that you ate or meals that you skipped in the day before your headache. So in general, I don't tell people to keep food diaries. I generally tell them, when you have a bothersome headache, write down what you ate for your last 1 or 2 meals before. And then you kind of retrospectively see like, sausage, pepperoni, hamburger, other things with nitrites, or I had a, big red icy, I had a big gulp fruit punch, etc. And then they kind of get like, oh, wow, that seems to be correlated. But so instead of writing down everything you eat, I would write down what you ate right before. And then you ask them like, oh, do you eat that every day, or is that kind of unique for those days? So back to the question, not a classical type of headache, but in terms of skipping meals or eating really high sugar foods, we want to see if that's a pattern for our patients. And I'm going to skip through this, but this is just an example of actually our template that we have for a patient. And so in general, there's choices that you can click on to fill in these questions to help illustrate the headache history. So again, characterizing the headaches, what they tried for treatment, how did it affect their daily activity. I'm just going to skip through this for the interest of time. And then their lifestyle habits in terms of sleep. You know, when do they actually, and also another thing is, you know, again, from talking with parents and patients, you know, say, oh, bedtime's 8 o'clock. And then after, you know, things being challenging and going back, and they're like, oh, but then, you know, he stays up and he's on his phone. I see the glow under his covers. I open the door and he's on his phone. You know, he's actually sleeping at 10 o'clock, et cetera. So I try to say, not your bedtime, but tell me when you're actually asleep. So sleep times, not bedtimes. And then we're asking them to monitor for signs of OSA, kind of their meals. I try and give them an example of what's a cup, or, you know, water bottles like 2 cups, etc. We talk about healthy stress and unhealthy stress, etc. So it tends to be a long history-ish. It's more efficient when we have them fill out these questionnaires in the waiting room, again, so I can provide those intake forms for you to use in your waiting room. But the history is so important. So I mean, if we gloss over this, we miss big things that we can help out the patient with. And so it's worth the investment, you know, really worth investment to document all these things, although it seems kind of like, why are we talking about what they like to do for fun? But partly because if they don't do anything for fun, that's already a red flag. Okay, enough of that. Going on again, the majority of patients with migraine in childhood have a family history of migraine, but not all, about 70%. But also a large portion of adults with migraine don't know they have migraine. They say, oh, I don't have migraines. I just have pounding headaches that make me nauseous. And sometimes I get sensitive to light. That's migraine, but they may not have been told they have migraine. So a lot of times I'll just ask, do you have bothersome headaches, and kind of expand from there. But again, not having a family history doesn't exclude the diagnosis. And again, for the history, some things we want to look at: the OSA predisposing features, making sure we're not missing neurocutaneous findings, affect and mood kind of things, checking their optic discs, checking coordination. And so things we don't want to miss: head circumference more for younger kids, but I think I covered those. And so again, getting to red flags, things I think that folks already are aware of: if they're increased ICP signs, that persistent progressive course that we're talking about, any focal neurologic signs, I'm sure we're probably going to get a call, or they're going straight to the ER. Sometimes focal neurologic signs show up later, so they may not show up with the first headache, but definitely if they ever show up, we do want to pay attention to that. Another thing that sometimes raises concern is about, we often get the sort of cliche about the worst headache ever, which often is subarachnoid hemorrhage concern in adults, but everyone has already had their worst headache ever. And so at some time you're going to have a bad headache, and that's going to be the worst one ever. But the thing that's more sensitive to me about hemorrhagic problems is extremely quick in onset, meaning I was totally normal, and within a minute or two, I felt like my head was going to explode. And so that's more the course of something that is worrisome for a vascular problem, as opposed to, it's the worst headache I've ever had that came on, you know, over an hour or two. Again, please chat in questions along the way, comments. I'm not going to go too much over increased ICP signs, but super important. Again, will change the course of management. Often we're looking for papilledema. Sometimes impaired upgaze may be more subtle for younger patients, or slight 6 nerve palsies. Yellow flags don't necessarily mean better go to the ER or better get evaluated that day. But less typically things on the neck or occipital area, that's less typical for primary headaches in general, not an automatic problem. Young age, or of course, other health factors, whether it's sickle cell, which can predispose to stroke, other things that might predispose to opportunistic infection, vascular problems, neurocutaneous conditions, which can predispose to mass lesions, etc. So of course, these will trigger also an approach in a different way. But we do have some shunted patients with hydrocephalus who have migraine. So again, even it makes it a little more complicated, but we still treat their migraine as a migraine and need to still distinguish that from a shunt problem. Another question from the audience in the interval time. How do we distinguish headaches from flus or poor hydration and anemia? I think a lot of this, as you folks would expect, will come from the history and exam in terms of other associated symptoms, whether it's for flu, hydration issues, and or anemia. So adequate hydration, will help minimize headache activity, but it won't completely necessarily eliminate it. So similarly, sometimes folks get concerned when now they're really hydrating adequately, but they're still having headaches. Again, we're just trying to bring down the frequency and severity of headaches overall, but at the same time, we may not be able to completely eliminate them. Hope that answers the question. Again, let me know if not for the person who asked that. And neuroimaging, I think, should just be done selectively. There's actually a choosing wisely, or several choosing wisely analyses that talk about not getting brain imaging for headache in general, and that it should be for select patients for a number of problems. So, for certain conditions, we do need to evaluate further. One that often comes up is awakening from sleep. And so this is different from the patient who, in half hour after getting up in the morning, maybe after going to sleep late, has a headache, as opposed to the patient goes to sleep and in the middle of the night, they wake up grabbing their head in discomfort. Oops. So the patients with sleep apnea may have morning headaches as a consequence of untreated sleep apnea, but the patient with kind of hydrostatic dependent increased ICP problems, when they lie down for a prolonged period of time, their head ICP may rise, and then they'll get a bad headache that may awaken them from night and cause them a lot of discomfort. So awaken from sleep, not having headaches sometime after awakening in the morning, but more like awakening out of sleep and pretty consistently. Again, imaging in patients with headache, this other series, several hundred kids with headache, all of the ones with space occupying lesions had abnormal exams. So again, just some reassurance there. And then we talked about the trends, about some that might indicate a need for imaging. And of course, other concerning family history might raise the suspicion. The other pitfall is sometimes folks do get imaging without those criteria, and we find a lot of stuff. So one thing that often comes up are these non-specific bright spots that can be seen in the white matter. They are commonly seen with migraine, and that's what all folks say, is that they can commonly see. But again, the hard thing is, and then it's going to register as an abnormal brain imaging study. But these are often found in patients with migraine. And also you can find other things, whether it's arachnoid cysts or DVAs, that again will raise a lot of anxiety because they're not normal, but they're also probably incidental and not contributing to symptoms. Oops, that's misspelled there, but the Chiari-1 would have more of the typical occipital, top of the neck, bad headache, worse with Valsalva. So that's, again, that is a surgically treatable condition if it's very severe, and we do have a few patients that we've sent for treatment, but I would say more often than not, the Chiaris are incidental findings. So again, once we've gotten past the red and yellow flags, super important to provide counseling and optimizing lifestyle habits. And this is really somewhere where we can kind of be um, really help families. They really appreciate it when headaches are bothersome and they can get it under control, and so much all the more by not needing a lot of medication. So, in reality, for a lot of patients who are coming in complaining of headache, I would say a lot of them can get things much improved by improving their lifestyle habits, but it does take time. It does take follow-up. We talked about things that would make me categorize headaches as more bothersome. And now to focus more on the primary headache. So now we've ruled out a lot of the red flags. And so for the primary headache problems, in early childhood, there might be these precursor signs patients have. I've seen a few of these cases, but they're not that common. Paroxysmal torticollis, BPV, patients suddenly get dizzy and kind of ataxic, might last for a few hours and they get normal again. And cyclic vomiting, we hear about, but interestingly also is treated often with migraine type medications that can help the patients have fewer attacks. A lot of these patients have family history of migraine and end up having more typical migraine as they get older. But again, you might get this previous history for some things that are typical for patients with migraine. Oh, okay. So another question from the audience. Is headache a diagnosis or a complaint? Just a complaint. So I think, as we work up different conditions, so diagnosis would be kind of describing the disease or the underlying cause, which then has, some epidemiology and treatments that have been tried, et cetera. Whereas headache is kind of more the presenting complaint. But in the beginning, we just know it's a headache. And so part of it is trying to sort it out. Sometimes we might not have a definitive diagnosis if it's the first headache the patient's complained about and we're still working it up. So sometimes the diagnosis will be non-specific headache. But as the patients have a pattern of certain headache types, then I think you can say, headaches, suspect migraine. And then once you see it's a stereotypic type of headaches that meet the criteria, then you can diagnose migraine. So I wouldn't see headache as a diagnosis in terms of encapsulating what a diagnosis is, in terms of the etiology and the excluding other causes, but it may still be the descriptive impression until you get more information and follow the patient up long enough to make the diagnosis, if that makes sense. Kind of like sore throat, could be strep, it could be viral, it could be like EBV, it could be mycoplasma. It's sore throat until you get the cause, or it may just end up being non-specific sore throat and goes away. So, so I hope that makes sense in terms of headache's not a diagnosis, but it may be all we have early in the course of evaluation. So migraine with aura, most typical of the patients with migraine, most typical type, only a small minority have aura, and usually pounding, I say, is it pounding severe lasting hours? In adults, it tends to be unilateral. In kids, they don't require that. And so usually if they're coming to you, it's not going to be they're not going to say, I'm coming to you for a nothing headache. So to fake that, the thought that they're bringing it up, probably it's moderate severe. It just shouldn't be lasting seconds. If it's lasting seconds or a few minutes, then I can't say that it's migraine. I would put a plug in for occipital epilepsy. So that is well, maybe I'll mention that with migraine R, but that can be a little bit of a confusing migraine-like condition. But otherwise, in general, I'd say pounding headaches lasting hours with one of these symptoms, and then often relieved by sleep, and then you need it to occur at least 5 times to make the diagnosis. So maybe it's 2 times or 3 times, can't fully say it meets the criteria, but once it's recurring 5 times is what they chose, then you can say, okay, it meets the criteria because we've ruled out the red and yellow flags, and that's it. So no imaging needed. And then Then, well, I'll talk more about counseling. Migraine with aura. These are pictures or made to represent kind of the visual aura. That's the most common kind of aura that folks see, but it can have other sensory motor symptoms. And often it's supposed to last less than an hour, usually minutes. And then often it's followed by headache, but not always. So sometimes they might just have acephalgic migraine, meaning just the aura and then no headache. And again, often it's much better with sleep. And usually you just need 2 of these kinds of attacks to diagnose migraine with aura. Some patients have a mix. Sometimes they have aura, sometimes they don't. So sometimes it's kind of a little bit muddied, but just that's the other type. There used to be a whole lot of other oh shucks. Sorry, that's a typo there. But there used to be a whole different subgroups of vestibular migraine and basilar migraine and complicated migraine and hemiplegic migraine, which are all other types of migraine with aura, which are pretty rare, but can have more focal deficits. So again, I wouldn't expect necessarily this to be diagnosed on the first pass. Now, often patients with hemiplegic migraine are getting multiple MRIs, but again, not real common presentations of migraine. And so again, 2 attacks. Most of them have visual aura, and I won't go into more detail here, but typically followed by headache. And usually the aura has to be more unilateral and brief. Other types of primary headaches, which I won't go into too much. Tension type is described as the band. Sinus, everyone knows about kind of the sinus pressure. Often migraines are written off as sinus headaches, but again, we want to ask for those other distinguishing criteria and cluster. So tension, kind of mild, usually not too bothersome, not bringing up too much attention unless people talk about having it all the time. Cluster headaches have more of this right stabbing in the eye and around this part of the face. They tend to be occurring in clusters, as noted here, kind of temporally. And the thing that also is unique with them is they tend to have all this kind of eye symptoms of red eyes or teary eyes, etc. Unilateral kind of running nose, etc. They're interestingly very responsive to oxygen therapy, but again, not real common. Happy to see these patients if they're, they seem strange and unusual and bothersome. Chronic daily headaches, defined as having headaches more than half of a month. But again, we want to make sure it's not persistent and progressive, and then check for predisposing factors. Are there more stressors? Is the patient depressed? Do they have untreated OSA? Are they using pain medications, day in, day out, for too many weeks at a time? So this is also new from the last time. So sometimes these are Q&A about with this Dr. Hershey on one of the Migraine Association pages. It says, education is so crucial to help patients and their families. So they ask, why do they have migraine? There's a genetic basis, can run in families, but often parents may not always know about them, or they may have outgrown them. How to make it better? Understanding the sensitivity of patients with migraine and adjusting lifestyle habits is really how they can best take control of their situation. I keep using my cursor on the wrong screen. And will it get better when I grow up? Well, that depends probably on hormone factors. For boys, a fair amount of them outgrow it, before they become adults, whereas females actually have an increased incidence of migraine through adulthood. And so again, just emphasizing maintaining good lifestyle habits in transitioning to adulthood. So one of the adult docs who talks about headaches says, why do people come to you for headache? Because everyone has headache. Why do they feel like they need to see a doctor? And his thrust was, they come to you because they're worried about a brain tumor. So sometimes that might be why parents bring patients in to get seen. And so it's that provider he's an adult neurologist, but he said you have to look them in the eye and tell them that you consider the possibility of brain tumor. These are the reasons why I think it's not. And go through the things that were assessed. There's no papilledema. The neurologic exam is normal. He's not having this chronic progressive course, etc. There's studies with imaging that don't show that show that these are other factors that are usually seen. And also, folks don't fully realize that we don't have pain receptors in our brain parenchyma. We have pain receptors on our meninges and our blood vessels. So people can have a huge mass in their brain that causes no symptoms. It might cause focal deficits later, but it's not like that's the only cause of pain. So more often, again, pain centers are coming from our lining of our brain or blood vessels. And again, you're going to get tired of me saying it, but I can't say it enough. Objectively tracking lifestyle habits and optimizing them. And so sleep, hydration, screen time, stress management, diet, physical activity. I'd say all of those have to be covered and objectively kind of described how the patients are doing on a consistent basis for us to say, okay, they've optimized their lifestyle habits, nothing more we can do there. So much of the time, there's a lot more to be done there. And so.
Can I interrupt and ask a question that I think might be in the minds of a few other people? I feel like as doctors, we talk a lot about lifestyle interventions for any number of things, obesity and, excessive screen time and all of the negative effects of that. But I think also a lot of times we see that our advice is very hard to follow, and that, we might even in ourselves, right, see that we have good intentions to do better, exercise more, eat healthier, sleep better, and so on and so forth. And that sort of over a prolonged period of time, it may not be consistently either possible, feasible, or just may not be done, even though you think it should be done. Are there any interventions, programs, or anything else that can sort of help, that's like data proven to show people, like to help people improve those lifestyle habits that are so difficult to change? And do you sometimes consider medication when they fail to optimize their lifestyle habits, even though that would work better?
Yes and no. So I would say it's more challenging for the teenage patients. So a lot of times our younger patients, they're kind of just following instructions from their parents, or hopefully trying to. Part of it is, so what often is the referral problem is Tylenol not working or ibuprofen not working. And what I try and tell them is, that ibuprofen cannot sleep, hydrate, de-stress you. It won't, provide you the nutrition day to day, which if it's the problem, we can't expect the medicine to treat. So that's one. Two is I sometimes, if it's kind of volitional, like, yeah, but I don't want to, have less time on my phone. I don't want to go to sleep early. Then I say, well, you've come in for bothersome headaches. This is what I would say can help. And so either it's not bothersome, or we got to work on these things. Because I think that, again, the impasse comes with the mom saying, oh, they're missing school once a week because of these terrible headaches, and the medicine's not working. They're staying up to 2 a.m. on Saturday. There's no medicine that I can give that's gonna suddenly make the headaches all go away. And so sometimes it does come down to, like, this is the deal. Either they're not bothersome and you can stay up to 2 a.m., but then don't complain to mom about them, or they're bothersome and you got to take responsibility for it. But as you're saying, some of it's kind of the judgment of, is this the best they can do? And we don't want them to suffer. But I would be very cautious about escalating medications and doses and adding things on, putting prophylactic medications on for someone who hasn't optimized things yet, because then we just get into now we're adding potential side effects. The medicine's still not working, but nothing's going to work until, we at least have these reasonably optimized. I would say that for some, for some patients, again, that time with the social history, I've had patients who are class officer and in 4 clubs and playing 2 sports, and they're doing extra lessons. They're going to, and it's just like that they are trying their best, but there's no way they're going to get to sleep on time. And so we've negotiated dropping classes, take 1 class down from AP level, cutting out clubs. And so sometimes it's even that kind of non-pharmacologic lifestyle. They are trying to do all these things, but there's no physical way they can get to sleep on time. That's because they have a crazy, they're, super high achieving, will never quit on anything. And sometimes it's giving them the permission to, this is best for your health. It's going to be the best balance for everything else to do well by taking out 1 or 2 things. So I don't know if that answers. So yeah, I have told patients or parents like we got to drop things because they're just spread too thin.
Thank you.
So that's both the high achiever and but I don't want to go to sleep early. That's the two extremes of the failed to. So here's kind of what I talked about: decreasing CBT, relaxation, teaching him that there's a interplay between being stressed and suffering headaches, and stress management is treating your headache. And I'll go further. So lifestyle habits optimized. So this is tier 2. So foundation, optimizing lifestyle habits. Tier 2, rescue treatment. Main things, we want adequate doses. So a lot of folks will give half the dose, or they'll wait for it to be a bad headache. Works much worse that way. Want to give adequate dose at the onset of bothersome headache. There are some strategically described, migraine headache medicines, but really they're combinations of others. Some make you sleepy, some might help with caffeine withdrawal. Not a super big fan. One big thing I would say though, if they're well controlled, I don't change them, but if they're not having good control, I often take them off these. But one big thing is, even though migraine headaches are super severe, true migraines, people look pretty sick and debilitated. Opioids can actually make management worse. So I would not recommend opioids in those settings. Speeding through, we know that there's environmental factors that can have release of neuropeptides. The triptans are one, but there's a newer group of CGRP type medications that are also being used in adults, not available for kids yet. And then it leads to the migraine symptoms where the brain and blood vessels are hypersensitized to pain. And so, last time was rush. We didn't get to talk about it. Not responding to Tylenol and ibuprofen. Again, I would go back and beat the dead horse, because often there's something to be gained there. Are the lifestyles optimized? Are they taking adequate timely fashion? Are we sure there's not other things contributing to the poorly controlled headaches? Then we can add triptans. So it's annoying. You may have talked about it at the last visit, but maybe they're lapsing in some area that can be addressed before adding a different kind of medicine. But the triptans, there's a wide variety. Many are actually, none were FDA approved a while ago, but slowly more are getting approved for kids. We do use some other types of medications for status migrainosus. That's outside the scope of this talk. Those are people who often admitted to the hospital or coming to the ER. In general, I usually tell them about nausea, flushing, and some dizziness. Most times they say there's some flushing. There's rare vascular complications, which sound very scary, but usually these are in adult patients with predisposing vascular risk factors. So I wouldn't say that we see it very commonly at all in kids. And so lifestyle habits before escalating treatment. And then, so again, most patients will be managed with lifestyle. Some may have to go to triptan or, some will have to go to triptan or prophylactic treatment. Let me show you this pyramid in a later time. So prophylactic treatment are for patients who have optimized lifestyle habits, are taking rescue medications to help with their headaches, but they're ending up needing the rescue medication too often, or the headaches are still not improved enough so that they're missing school or sports or can't do homework, etc. And so often if they're having headaches more than once a week or missing school more than once a month, and they have all their lifestyle habits optimized, then I'll try a daily preventative medicine, which has to be contrasted from the rescue medicine. So it's not a PRN, it's a everyday medicine. And gradually over time, they do tend to reduce headache severity and frequency. There's a New England Journal study, I think a few years ago, that talked about how preventative medicines were no better than placebo. They both were helpful. But to me, one shortcoming of that study is that those patients had frequent close follow-up, and it's not clear to me that all their lifestyle habits were optimized before they started the prophylactic medication. So anyhow, I think the general practice still in the community providers is that, prophylactic medications still work clinically by experience, and we still use them for this subgroup of patients who are refractory, even when we've optimized lifestyle habits. But it's important to let them know that it's not going to be a quick fix, but it can be quite helpful. Another thing is about also saying sometimes parents will still be concerned, oh, they're still having a headache. But again, we're trying to get the headaches down to a manageable level. It may not be zero headaches, but we're trying to get it to a level that they can still maintain their daily activities. And so another question, what's the drug of choice? I would say there's not one. Different patients respond differently to different triptans. So if they're not responding well to one triptan or to one prophylactic medication, I'll change them out. But I would say the vast majority of patients we can help in a substantial fashion. And so in that small portion that aren't getting good control, we again have to always circle back. Do we have the right diagnosis? Are there other things, again, that I'm not aware of that are exacerbating it? And maybe, we have to send it to a headache specialist. So, which reminds me, so in the interval since the last time we talked, we do have a local headache specialist, Dr. Pedraza, who joined HPH. I feel maybe I shouldn't have mentioned her name, but she's an adult headache specialist who very kindly we've been in communication with, and she is willing to help us with our older patients right now, 15 and over, with refractory headache. And so we have redirected some of our referrals to Dr. Pedraza. But so nice, and she loves headache. She wants to see headache all day. Right now, we have it at the 15-year-old mark. We'll see if we can get it lower, but just FYI that we do have a headache specialist in Hawaii. Other interventions, so school notes, again, getting the school to understand that migraines are episodic and not always easily controlled. CBT to help with stress. Sometimes the nausea and vomiting are the worst part of the whole migraine experience, and sometimes focusing in that area can be helpful. Otherwise, I don't recommend CBD or piercings, etc. And there are some other treatments that are being studied. Again, the CGRP blockers, Botox. Again, that's for a select group of intractable chronic headache patients. But again, those I think would not be expected to be managed prior to referral. And so we'll put out there's a headache referral guideline that's being will be made more available. I'm not gonna go over it in detail here, but it kind of recaps what we talked about earlier. But again, the bulk of patients with headache can be really managed with these foundational approaches. And for the minority that can't, then those I think we can try and help through a referral process. But it would be really help if these ones were addressed first. And that will cut down the referral volume quite a bit. So back to the CME. Don't need a